Good afternoon. Thank you so much for the kind introductions. First, I would like to thank the SOAP for awarding me the opportunity to present my dissertation, which is titled Gestational Trophoblastic Disease at Parirenyatwa Group of Hospitals, which is a retrospective study which I did from 2021 to 2024. I have no disclosures to declare, but I would like to acknowledge the participants of this research. Also, I'd like to acknowledge Parirenyatwa Group of Hospital staff, as well as the medical staff, as well as the Joint Research Ethics Committee, who afforded me the opportunity to carry out this research. So, gestational trophoblastic disease is a spectrum of disorders which arises from abnormal proliferation of placental tissue. The incidence varies widely, with a audit which was done in South Africa reporting about 1.2 cases per 1,000 deliveries. GTD has a high cure rate, coming from the benign lesions, approaching up to about 100% cure rates. Even some of the metastatic disease also approaches up to over 90% of treatment of cure rate. So it is important that we identify this disease early to avoid metastatic disease. I will just talk about a bit about the spectrum of GTD. We have got two forms of GTD: the non-invasive forms, which comprises of the complete mole, which is wholly paternal derived. This complete mole has got a propensity of about 15 to 20% to become persistent trophoblastic disease. And we've got a partial mole, which is got which comes from the both maternal and paternal origin. This has got a lower risk of propensity to become malignant, up in about 1 to 5% of cases. Then we've got a whole complex malignant spectra, which is called gestational trophoblastic neoplasia, which involves locally invasive mole, which in this case we're saying that trophoblastic disease, the trophoblastic tissue is now invading the myometrium, going on to the spectrum, which involves choriocarcinoma, which is the most common GTN, and we've got some rare spectrum of this disease, which includes placental-site trophoblastic tumor, epithelial trophoblastic tumor. These are more chemo-resistant, but they can be managed by surgery. So coming on to Zimbabwe, our local data is lacking, and prior to this study, there has been no published data on GTD in Zimbabwe, and it is important to understand the local epidemiology and presentation so that we tailor our management protocols, which suits our current resources as well as our current capabilities. So the aim of this study was to characterize clinical presentation of GTD at Parirenyatwa Group of Hospital. The main objective being to try to come out with a hospital-based prevalence of molar and GTN, and to describe the common clinical presentations of each, and look at factors that are associated with the GTN, FIGO, WHO score, risk levels. So we conducted a retrospective review for GTD cases, which were diagnosed between 2021 to 2024. We looked at existing medical records because we couldn't do a prospective study because of lack of a GTD registry. We conducted this study at Parirenyatwa Group of Hospital, which is the largest tertiary gynecological oncology center in Zimbabwe. And being a referral center, we know that it captures most of the GTD cases nationally, So it was the perfect site for us to conduct this study. We included all women who were diagnosed with GTD between January 2021 and December 2024, and we excluded incomplete or missing records, and we came up with a total of 148 cases that made out our cohort. So during this time, from January to 2021 to December 2024, there were 46,000 total deliveries that were recorded. So I'm happy to report that we now have a hospital-based prevalence of 3.2 cases per 1,000 deliveries that we found out from this study. In looking at the social demographic profiles of these women, we note that women with molar, they were up to 6 years younger compared to women who were diagnosed with a GTN. And we noted that women with molar pregnancies were more coming from urban areas as compared to the GTN, which was more coming from rural areas. And we also noted that women with molar women with GTN were more likely to be high parity women in our study. And what was interesting is that we noted that about a third of molar pregnancies were diagnosed in the first trimester, which is less than 13 weeks, and the mean gestational age at diagnosis was approximately 15 weeks. So which means a lot of these women presented with symptoms. And the most common presenting symptom was vaginal bleeding, which comprised of 85% of the women presenting with vaginal bleeding. We also noted that about 4 out of 10 women were reported passing of graphic vesicles, and we also noted that only 4.3% were diagnosed by ultrasound scan without symptoms in the first trimester. So, and it is important to note that all these 4.3% who were diagnosed without symptoms, they didn't have any complications arising from molar management or the disease itself. And what is also interesting to note is that we noted that proteinuric hypertension was prevalent about 4.7% in the women who had molar. So coming on to the GTN, the whole presentation, but it's okay. So what we found out is that about 70% of women with the GTN were diagnosed post-molar, and you know that about 13% of them were diagnosed post-abortion, and then we had 16% who were diagnosed post-full-term pregnancy. So this means that this study is now showing that 18% of cases were identified during follow-up after suctioning. Both in terms of molar, when you manage molar, we expect the patient to be followed up with surveillance, but only 18% of cases we followed up during surveillance and they were diagnosed, which means that 80% of women were not followed up. And at presentation, 24% had chest metastasis and 74% had neurological symptoms at presentation. In terms of comorbidities, we noted that GTN women were more likely to have the majority of major comorbidities, including HIV, hypertension, thyroid dysfunction, as compared to women with molar. What is interesting, we also noted that 14% of prevalence of HIV was much higher in GTN compared to molar. I think this also speaks to the national prevalence of HIV, which kind of peaks in the women, which kind of peaks around the age of 50, around the age of 40, 45, then also goes down after the age of 45. So in our cohort, we noted that our GTN women were much older than molar, So which may explain why we noted that slight increase in HIV. We also noted that in terms of thyroid dysfunction, it was more common in GTN as compared to molar. It is explained because we expect these women to have a high elevated HCG levels. Then in terms of anemia, severe anemia was more common in GTN with HB of less than 7. As compared to cases with molar. And transfusion itself was more, there appeared to be a higher need for transfusion in molar pregnancies, but it was not statistically significant. In terms of risk stratification, this study is just showing us that more than 80% of women with GTN at presentation had either high risk or ultra high risk at diagnosis, which is speaking to late diagnosis. And more than 50% approximately 50% of the GTN cases had lung metastasis, and 18% had brain metastasis at diagnosis using imaging. In terms of management, all GTN cases managed to receive chemotherapy, and the regimens that were used, methotrexate alone was used in 18%, MRCO was used in about almost 40%, and then induction chemotherapy followed by MRCO was used in 42%. This also speaks to the willingness of the providers to stick to the international protocols in terms of management of GTN. What were the outcomes for women who were suctioned for molar? 100% of them managed to get suction, and a certain suction was needed in about 2.1% of the cases, and 3.2% of the cases required hysterectomy for intractable bleeding. In terms of transfusion, almost half of the molar cases required transfusion. But what is important to note is all these women who developed complications were those who were diagnosed after the first trimester. Those who were diagnosed without symptoms in the first trimester didn't develop any complication at all. And we also tried to look at the progression to GTN, and we noted that about 7.4% of women with molar pregnancy progressed to post-molar GTN. But we want to appreciate that it was not a complete follow-up, but this is just telling us that the progression to persistent trophoblastic disease is real in these women. On the ultimate outcome of mortality, the overall GTT mortality among the women that we looked at was 3.4%, and all deaths in this cohort occurred in the ultra high risk group, which also tells us that those who present late, the worse outcomes. In the cause of death was severe hemorrhage, hemothorax, or brain metastasis, as well as renal failure. So because we couldn't really follow up all the women, it was impossible for us to calculate the survival. But what we found out from the study is that we now have a prevalence of 3.2 cases per 100,000 deliveries, and the presentation of this GTD in this cohort showed two distinct profiles where we say molar pregnancy was more common in younger Asian women versus GTN, which was more common in older rural multiparous women. And we also noted that late presentation, particularly for the low first trimester detection for molars, was associated with a worse outcomes or complications, and more than 80% of GTN who presented late, it was also associated with worse outcomes with mortality as well. And the high burden of HIV and other conditions in GTN patients, which we noted, it will probably need further evaluation. But what was common was that the mortality was confined to the ultra high risk group, which just means that if we don't catch this disease early, the mortality and the morbidity will rise. Some of the limitations that we found that from our studies that we relied mostly on accuracy and completeness of medical records, and it being a single standard study, findings from a national referral center may not be generalizable to the entire population, and the hospital-based prevalence is likely an overestimate compared to population-based studies. We can still draw some recommendations from this data, which means that one of the recommendations is that if we improve early detection and by expanding first trimester ultrasound access in antenatal care, we can catch women with GTN early, and you manage them early, and the complication rate and mortality and morbidity will reduce. And also need to strengthen follow-up data, because we know there's a 5 to 15% risk for persistent trophoblastic disease. So we need to implement rigorous post-molar surveillance to identify these women. And we also need to address barriers to care, particularly for the rural women that we found that they're more privileged to present with left-side GTN. So efforts need to be also looked into that, and we also need to prepare for complications. We noted that over half of our molar women who presented late ended up requiring blood transfusions. So we need to put all those emergency measures in place. Right, thank you.